Now that the CMS proposed rule for 2023 has been released, our team felt that a short Q&A to clarify the RPM and RTM related items would be beneficial to our clients and any other listeners as well. We'll be reviewing what those acronyms mean in our video shortly for any of you who are not yet familiar with them. But before we get started, I'd like to give a quick introduction to who is speaking on this video. So I have with me here Sherry, and she has 15 years of revenue cycle and practice management experience, 5 years of RPM experience, and has been an active member with the AAPC since 2006. She holds the CPC, CPPM, and CPCO certifications. As our RPM implementation expert, she is our go-to resource for decoding all things CMS. I myself am a senior manager of business development and marketing here at Coach Care, and I felt it important for us to continue our efforts of sharing and clarifying information around RPM and RTM as it's released by CMS. We understand very well just how confusing a lot of the language can be, and we hope to be of help to you all with this Q&A session. So to Sherry, my first question for you is, how does the proposed rule affect the CPT codes related to RPM? And if there is an effect or an impact, how does it change them?
Hello, and thank you, Rebecca. So to refresh everyone's memory, the CPT codes related to RPM, that's remote physiological monitoring, are 99453, 99454, 99457, and 99458. Under the proposed rule, these codes have no change. Many were hoping to see CMS update their interpretation surrounding the 16-day requirements for codes 99453 and 99454. These codes are the practice expense codes in the RPM code set. Code 99453 is the initial setup and patient education on use of equipment, and 99454 is for the device supply with daily recordings or programmed alert transmissions. Both codes are 30-day codes requiring a minimum of 16 days worth of transmissions. For a lot of stakeholders, the 16-day requirement may not follow the standard of care or could be a barrier to care when we were hopeful that this would have been addressed in the 2023 proposed rule. What I mean by this is that there was hope CMS would allow for the less rigid 16-day requirement, but that did not make it into the proposed rule this year. Before we move to the next question, I would like to clarify what I mean by stakeholders. So this is a group of providers, insurance plans, medical device companies, or any other group that have a shared interest in the development and implementation of CMS's final rule.
So our second question is, will there be a payment reduction based on the proposed physician fee schedule for 2023?
We will see a payment reduction based on the proposed final rule. The conversion factor for 2023 is $33.08, and that's a decrease of the $1.53 from our current calendar year, 2022. The conversion factor is $34.61. So for those of you that are not overly familiar with insurance and billing reimbursement, the conversion factor is the amount Medicare pays per relative value unit. Each CPT code has its own relative value unit associated with it.
Got it. That makes sense. So moving on to the next question, what does this $1.53 decrease mean for stakeholders? I know we just discussed that. That's the change from this year to the next year, but what exactly should be anticipated of that?
Sure. So with the $1.53 decrease, it's a mouthful, on the conversion factor, you'll see lower rates of reimbursement for all CPT codes on the physician fee schedule in 2023. So it's a $1.53 decrease across the board because of that conversion factor. Right. So this is per CMS now. Payments are based on the relative resources typically used to furnish the service. So relative value units are applied, and those are RVUs, to each service of work for practice expense and for malpractice expense. So these RVUs become part of the payment rate through the application of a conversion factor. The geographical adjusters, they're also the geographical practice cost index, or GPCI, as we like to say in our community, are also applied to the total RVUs to account for the variation in practice costs by geographical area. So this helped reinforce that the codes They don't all decrease at the same rate, but you do see that there's a different percentage of payment reduction based on all of these factors. So really the bottom line is there's a decrease across the board, and there are multiple things in the equation to get to that number. Now, I would like to note that seeing a decrease is standard and it's not indicative to a lack of value. Regarding the CPT codes that our RPM platform supports, reimbursement decrease is relatively insignificant. So right now, an RPM patient being treated by a provider who uses our platform will yield on average around $140 of reimbursements monthly. Under this proposed rule, that same patient will yield an estimated $130 of monthly reimbursements. So for those of you out there that are good with crunchy numbers, you can easily scale this based on the estimated number of patients that are eligible for RPM in your practice.
Great. That makes perfect sense now. So the fourth question we have is, we saw a lot of requests from stakeholders for CMS to update the current RTM codes. Could you explain to me again what RTM is? And then did CMS respond to these requests? Did we see anything about that in this proposed ruling?
Sure. So RTM stands for remote therapeutic monitoring. It's a little different from RPM, which is physiological monitoring. So the current codes for RTM, the therapeutic side, are 98975. That's the initial setup, patient education on use of equipment, specifically around the respiratory system, musculoskeletal system, therapy adherence, and therapy response. The 98976 is the device supply for monitoring the respiratory system for 30 days. The 98977 is the device supply for monitoring the musculoskeletal system each 30 days. The 98980, pardon me, I'm so used to saying the RPM codes. The 98980, the first 20 minutes of monitoring in a calendar month with one live interaction, and the 98981, each additional 20 minutes of monitoring in a calendar month. So they do mirror and are very similar to your RPM codes. They're just in the medicine section of your CPT book.
Got it.
Yeah, and to answer the second part of your question, CMS has responded to stakeholders' requests for an update to these current codes. As the current codes stand, RTM would need to be managed by the ordering provider since they live in that medical section of CPT. These codes were not subject to the general supervision rules like the RPM codes are and we're used to doing. So under this proposed rule, CMS has created a new set of HCPCS G codes that allow clinical staff to be able to manage patients on an RTM program under general supervision. So this would allow junior staff to help support providers ordering the RTM services. And we mostly see this with PTs, OTs, registered dietitians, chiropractors, clinical psychologists, anybody that has access to bill medicine codes per their contracts.
Right. Okay. That makes sense. So our final question for you is, will RPM and RTM still be valuable to private practices, physician groups, hospitals, and health systems, considering these changes that we've seen with this proposed ruling?
Yeah, absolutely. The reimbursement decrease we discussed earlier will not be significant enough to negatively impact a practice's bottom line.
Got it.
Yeah, so aside from financial reimbursement, there are so many intangible benefits to both patients and providers. So some of the most notable benefits are faster access to care for patients, that increased accountability for patients that allows them to be more actively involved in their care journey, offsetting that provider-patient burden, especially during staffing shortages, because it allows your junior staff, your non-billable junior team members, to be able to monitor patients and then escalate to providers as necessary.
Right.
And that collection of that real-time patient data, it really allows for earlier intervention in the care journey. So that by itself is keeping patients healthier, keeping patients out of hospitals and ERs.
That all sounds great. So really sounds like, even though we're seeing that little bit of a decrease there, that, it's still something that brings value, both tangible, intangible, to a practice, really improves quality of life for the provider and the clinic staff by, expediting all of this and really clearing the way for them to be a little more focused on other things versus administrative and, patient care as well.
Yeah, that's exactly right. And, really being up to speed on the proposed rule when it's released by CMS this time of year is really a great way to stay in the know. It also shows how having a great RPM partner can take away the burden of having to do this research on your own regarding reimbursement, compliance, and anything else in this area of business. So that's certainly the goal that we strive towards with all of our providers and patients that we support on our platform, is to support them from compliance, reimbursement, and being just a well-rounded partner.
Right. Well, I could not agree more. Thank you all for listening to our Q&A on the CMS proposed ruling for 2023. As always, we hope you were able to make this we hope that we were able to make this information more palatable to you so that you all were able to learn a little bit more here today. For any of you who are interested in reading the source material, here it is up on our video. We'll be sure to include links that you can click on in either the video description if you're watching this posted somewhere, or if you are a client of ours and you received this in an email from either myself or Sherry, there should be a link in that same email that you can click on to go read the full article. And to all of our clients out there watching this that do read through, if you have any questions, please, of course, reach out to us. Sherry is our savior and can break it all down for you. Thank you again. We hope that you have a great day.
And thank you.